The FFR CT is a wonderful tool to improve the performance of CTA, CT angiography in patients with suspected coronary artery disease. Everybody knows that according to the new guidelines, CSC guidelines, now the CTA is a test that we can use as a first level to rule out the presence of coronary artery disease. But the main limitation of CT angiography is the limited positive predictive value in case we found obstructive coronary artery disease. The addition of FFR CT changed the paradigm, changed the practice, because it's able to improve the positive predictive value of CT angiography, and this way is able to limit the number of false positive cases. So the most important impact in clinical practice is to limit the unnecessary invasive coronary angiography in case of a positive CT angiography. The main aim of FFR CT is to avoid invasive procedures that are not necessary, but at the same time is a very robust gatekeeper to improve the people with significant disease to be referred to the cath lab. So, in general, the expectation is to reduce the number of diagnostic evaluation and to improve the rate of revascularization, appropriate revascularization in the cath lab. This is the main aim of FFR CT in clinical practice. The FFR CT is typically very useful when you have intermediate stenosis in cardiac CT. I mean intermediate stenosis ranging between 50% to 70% of lumen narrowing. Because in this specific setting we have two kinds of a problem. First, a potential risk of overestimation of coronary artery stenosis by CTA. Second, in case there is a true obstructive coronary artery disease intermediate lesion, the question that we have in mind is there is ischemia associated or not. FFR CT is extremely useful in this setting because it is a wonderful tool to resolve both limitations. First, to limit the overestimation. Second, in case of a correct estimation, to detect the presence of ischemia. In this way, we have a more efficient result from non-invasive evaluation. The main benefit in terms of cost effectiveness, as demonstrated by the platform trial, is to reduce the cost for management of a patient with suspected coronary artery disease. Indeed, when we have a diagnostic workup in which FFR CT is used as gatekeeper to a cath lab, the overall cost is lower than about 30% as compared to the standard diagnostic workup. This means that we can save a lot of money and at the same time to reduce the number of patients to be referred to the cath lab, and just to be more efficient to identify the patient that really receive benefit from the invasive evaluation. The main limitation of FFR CT is still the limited positive predictive value, especially in the subset of a patient with calcified lesion. Indeed, as you know, when there are calcification on coronary arteries, the performance of FFR CT could be limited. Of course, in this case, it is very important to check which FFR CT value we have. I mean that if the value is very low, a good chance that it is a true significant disease. But the problem is that when we have a value in the grade zone between 0.7 to 0.8 in presence of calcified lesion. In this specific setting, we need probably more information to add on top of FFR CT to be more precise. And one option is the stress CT perfusion. I believe that in the next future, the background of cardiac CT in general, and more specific FFR CT, should be part of the general background of interventional cardiology. This is very important because in the next scenario, the most common pathway that we will have is that the interventional cardiologist will treat patients in which everything was already studied in a non-invasive setting. And so, to this regard, it's very important that the interventional cardiologist has a general background about these new techniques. They are able to manipulate the images and to have a personal interpretation about the data, because this, I believe, makes more efficient also the strategy of revascularization in the cath lab.